Dr. Subhangi is here, right? So Dr. Subhangi is next with her paper. Any other speakers are here? What's your name, doctor? Anirudh. And any other speakers here? Okay.
Good morning all. Today I shall be presenting the clinicodemographic and etiological profiles in acquired esotropia, a prospective study. I have no financial interest to disclose. The primary objective is to study the clinicodemographic profiles in patients with acquired esotropia, to report the varied etiologies and to determine the functional outcomes in this subset of patients. Acquired esotropia can be acute or chronic in onset with variable progression. The prevalence of acute esotropia is 10.4% of the total diagnosed esotropia cases. It can be comitant or incomitant. In the comitant variety, acute acquired comitant esotropia is characterized by an acute onset of esotropia with an equal angle of deviation in all fields of cases. As per Burien-Miller classification, there are 7 types. In concomitant variety, esotropia with varied angles of deviations in different cases. Acute esotropia can have variable etiologies. The study was a prospective study conducted at the Department of Ophthalmology at KIMS Bhubaneswar with a sample size of 21. Detailed ocular and systemic evaluation of all the patients was done, and ocular and laboratory investigations along with neurological imaging was done wherever applicable. The inclusion criteria took diagnosed cases of acquired esotropia with an age range of 5 to 55 years and excluded severely ill or patients who were admitted in ICU. It also excluded infantile esotropia cases and also patients with history of previous ocular surgeries. The patients were followed up at first, second, third and 6 months. Statistical analysis done gave us a p-value less than of 0.05, which was considered as statistically significant. On coming to demographic parameters, the mean age was 32.3 plus minus 0.36 years. There was a male preponderance in our study participants. Most common presentation was bilateral. On best corrected visual acuity, from presentation to follow-up of 3 and 6 months, there was a significant improvement in vision from 0.5 to 0.2. Coming to etiologies, neoplastic origins were most common, followed by post-fever and ischemic. On lab investigations, D-range serum homocysteine, lipid profile, ESR and HbA1c was found in ischemic patients, and in idiopathic intracranial hypertension patients, there was decreased serum iron and ferritin levels. On OCT, 43% of patients had RNFL thinning, whereas 36% of the patients had RNFL edema and thickening. CSF analysis revealed 20% cases with viral meningitis, and CSF study with malignant cells was found in 26% of the cases. We did neuroimaging, which is MRI brain and orbit with contrast, and along with MR venogram with contrast wherever applicable, and which revealed a finding of raised intracranial pressure as the most common, followed by hyperintensity and enhanced lesion in 24.6% of the patients. On HFA, advanced field loss was the most common finding, followed by enlarged blind spot and inferior quadrant tonopia. Due to poor vision, 26% of the patients' vision field could not be obtained. Coming to discussion, the study conducted by Clark and Nelson reported acquired esotropia secondary to refractive errors, decompensated esophoria, and prolonged neowork. The study by Buick-Winding Lee revealed intracranial disease such as elevated intracranial pressure, tumors like glioma, Arnold-Chiari malformation, and cerebellar and thalamic tumors could be major etiologies. In study by Liu et al., in 30 children with acquired esotropia, 12 had comitant esotropia, while the rest 18 had incomitant esotropia. In our current present study, neoplastic origins were revealed to be most common, followed by infective and ischemic patients. So the take clinic message from this presentation is that majority of the patients present with acquired esotropia have neoplasia as a major cause. Patients with refractive accommodative esotropia are orthophoric at final follow-up. A detailed history, clinico-radiological evaluation along with appropriate lab diagnosis helps in clinching the appropriate diagnosis in the final follow-up. These are my references. Thank you.
Thank you, Dr. Subhangi. One question. You talked about neoplasia as a major cause for these esotropias.
Yes.
Now, were there any frontal tumors also reported in your neoplastic lesions?
Yes, sir.
Okay. So, do you think that the frontal tumors are frequently associated with raised intracranial tension?
Yes, sir. Tumors like meningioma frequently have raised intracranial pressure.
Because the size and the site of the tumors both are equally important.
Yes.
And when you talk about the site, the frontal tumors are generally not so frequently associated unless the size is very big. So I think the main cause in this scenario would have been the raised, all those tumors causing a raised intracranial tension. That would have been more appropriate.
So, Dr. Subhangi, I just missed that. How many, what was your study period and how many cases did you get?
The study sample size was 21 patients, and the patients were follow up at 1, 2, 3, and 6 months.
So, you mean sample size, you calculated the sample size, or you mean the number of patients you included were 21?
The number of patients at the final count was 21, ma'am.